your sense. Let me suggest that we've got about 23, 24 minutes left. I'd like to have questions from the public. Are you a person who has found some of the problems that Irene described as in terms of patients that you in your family or that you are willing to talk about? Are some of these structural questions still sort of vague in your mind? You need some sort of help in understanding sort of what it is that we've been talking about up here. Anything counts, and make sure that what we get is not a long statement by you, but turn very quickly into a question. If you don't get there within about 30 or 40 seconds, I'm going to go ahead and have and start interrupting. Do you want to?
I'll pass the microphone.
There's a question here, a question back there, and a question there.
Hi, Sally Geller from Woodcliff Lake. I was briefly in Bergen Regional as a patient and had a very perfect, fine, just, a good experience. I started to read the report this evening. I only saw it this evening, so I was concerned. There's a lot about, this is a big campus and they can build. I kept seeing building metal skyscrapers all over, and I'm really worried about that. I know we need to improve old stuff, but can you talk a little bit about plans?
There's going to be a need to rebuild those structures. The amount of money that it would take to rebuild it all, would be astronomical. And that's why we need to, I think, partner with these entities, non-for-profit, to partner together for the future to make sure that the capital expenditures are shared, because the financial burden, the county should not be in the business of hospitals, managing owning a hospital. Oversight, yes, we just don't have the money to do so. So I think to go into partnership and to share the risk of the capital expenditures, I think is the way to go. But there is so much that has to be spent to get that campus up to a state of the art. I can't even imagine how much that is, and we're not going to know until we get in and really begin to see that building by building.
And part of the reason that the RFP has been extended for 6 weeks is to give the people who are interested in actually bidding more an opportunity to sort of sort out those questions. So I understand it, and I hear numbers of $150 million just to get us to some place that would actually allow continuity of care that would be equal to what Sally just says that she experienced, which is good news. Do you want to have a question?
Yeah. Allison Moore, I'm a licensed social worker. I have experience working in community mental health centers at Care Plus, as well as training at the VA, and now here at TN Public Schools. And I'm just wondering, in this big transition, how is our transition to this fee-for-service kind of model going to affect our mental health services in the hospital? Mom? We did not discuss this.
But you know who you want the answer to. Is that right?
I don't know every
Classic.
And that really has not been sorted out. We've had a great deal of worry from providers on the mental health field on how this is going to actually work, and we have not gotten satisfactory answers from the administration as yet. So I don't really have an answer to the question, except everybody's concerned.
Right, and we can feel it down in the community mental health centers. Morale is very low. It's very low, and it's affecting treatment.
And is that somehow related to the BRMC issue?
Yes.
Or?
Yes, because that's...
Help us understand what you're saying, so we understand.
So a law was just signed by Governor Christie that our mental health will now move from a community mental health kind of service where we accept entitlements and things like that to a fee-for-service where you have to pay for the service. Where not all insurances will take that, nor even pay reimbursed for that. So the mental health centers are looking at a huge amount of money lost, and I'm wondering if the hospital will also lose a lot of their resources that they need.
Well, you remember those numbers I showed up there about that enormous difference between 2016 and what they're in 2000,
Right.
2015 and 2016, so it's
Well,
already
except
going up.
that part of that is we have a much higher insured population
Right.
now.
Of course, and that's probably what, the other point is that there is that the Medicaid piece is picking up. Remember that $11 million as compared to the $16 million? That's actually playing in that process. Are people going to get caught in that? You know they're going to get caught because you're dealing with it.
You know,
Medicaid, there's no copays.
so what you're asking about Medicaid is not the issue, because Medicaid is no copays. The problem that we have in New Jersey is that there are no physicians who are willing to take behavioral health Medicaid. And they've been excluded from the managed care programs, so they're now being handled by, it is the only fee-for-service where the doc service in Medicaid, mental health, and it's being handled by Rutgers Behavioral Health Center.
Right, so the resources will go down.
The reimbursement rates will go down?
Yes.
Not unless we improve the Medicaid reimbursement rates.
Well, let's do that.
They're the lowest in the country, apparently.
And it's really important when you look at the overall cost of things, because if you're not getting treated in the community, which is reimbursed at a lower rate, it costs a lot more in the hospital. So you have to really coordinate from the get-go the community system.
You got a question back there?
Good evening. My name is Muhammad Dawood. I'm an imam and a chaplain over, as well as a volunteer Muslim chaplain over at the Bergen Regional Medical Center. I have to say that I've been there now for about 15 months, volunteering my time over at Bergen Regional Medical Center as a chaplain, volunteer chaplain. And I have to say that it is, truthfully, we have really shortchanged ourselves. Working with people who are trying to detox out of heroin, dealing with senior citizens who have serious diseases, not just Alzheimer's, but all kinds of diseases. And really, truthfully, the way I think of it is like, look, we are a village. We are a village. And if our hospital is taking in senior citizens who are poor and indigent and need help, then we need to really truthfully, as a community, as a village, say, okay, whatever you need, we'll provide. I lived in London. I've dealt with East London Mosque, and there was a hospital right across the street called East London Mosque. East London Hospital. And they had a serious rehab problem, just like we have over here, but over there in Europe it's even worse. The problem is that basically in Afghanistan, which is about 8% of the heroin, I remember a sheikh and a scholar said to me, you know, they fight us with lead, but we fight them with heroin. We have to say to ourselves, look, only one out of 5 gets into Bergen Regional when they walk to the door and say that we need some rehab help. These are young kids.
So you're suggesting that the
Immediate help
admissions rate of people that you're seeing and know about is
very, very low.
okay.
I would say if there's 5 people going there, maybe only 1. If there's 10, maybe 2 get admitted. And the rest are turned away.
Irene, do you see that?
And we got a lot of people who are overdosing, young kids. But now the problem with, actually, I'm old enough to remember heroin. It was always a problem. But it had a black face. Now, because the cheapness of heroin and the potency of heroin, it has a white face. So we have to say to ourselves, you know, look, as a minority, like I say Black Lives Matter, we did rehab in my generation, my people who I grew up with, we did rehab in prisons. Now it's a fight to build hospitals for your young, for the youth. So you have 2 problems, senior citizens and the youth. That's what Bergen Regional, I mean, I've been working there now working, walking those halls and dealing with those patients there. Dealing with those patients there.
What's there?
What's there
is that
you have a lot of angry people. That's why you have a lot of fights. And then they call out on the announcements, Dr. Strong, Dr. Strong, Dr. Strong. And everybody knows in the hospital, even patients, that somebody just blew off and just went to a tangent and just start fighting nurses or anybody to come around. People are angry. And people have diseases. And they're shortchanging the nurses. That doesn't help. This idea of privatizing hospitals is a loser because it's about profit.
Well, you did understand that there was a question for a long time in the county as to whether or not the county was going to maintain continuing ownership or whether it was going to actually be sold to a nonprofit institution. In fact, there's one freeholder candidate who's currently advocating that. And that was actually specifically not agreed to either by this report but the issues that you heard.
I heard them clearly, and they're all sincere and they're transparent. But see, the problem is, as myself, I look at it in the spiritual sense, is that, look, you're dealing with life. Don't put a price on it. If it was me that was running the show, whatever funds you need, you get. Because you could be dealing with my son or my daughter or my parents. So, I say to myself, why are we putting this in a system that is based on profit when we can be able to keep it in the county and be able to say, look, there is a life value, something we can be proud of. It's a hospital, we need more beds, we build it.
Does anybody on the panel want to respond to that?
Well, I was just going to say that I think insurance is a big issue, and I liked in the proposal that they're considering accepting other insurances. Because you can have really good insurance, for example, Blue Cross Blue Shield, and you cannot go to Bergen Regional.
That's right. So why put insurance as a barrier? Whoever comes, they get it. Because the poor, they don't have insurance. The poor, for everyone that knocks the door and gets admitted, I would say about 5 or 6 are turned away. They don't have insurance, they're dirt poor, they're indigent, they live on the streets, they live in the gutter, they live on the bridges, they live in abandoned homes, or they're addicts. And if they don't, it's the worst thing in the world is to turn an addict away. Because he came to your door and knocked. Now if you turn him away, that means that person can OD that same day.
Well, I'd like to have the panel have a chance to respond.
That's a response of it. I think this is probably like what you're saying is what we all struggle with every day, especially our healthcare providers, our legislators. I mean, everybody is here looking for the welfare of people, and life does come first. I mean, I know it's our play, like deep in our heart, but the reality is right now is the healthcare system in this country is broke, and we have to work with what we have.
And if I could just make a comment, is that the biggest employer of Bergen County is Hackensack Hospital. The second biggest is the County of Bergen. So whether we like it or not, healthcare is a business. Now, how do we go about making sure that the most vulnerable are protected? I believe this advisory board that was set up started that process. I think the authority is going to continue that process. But ultimately, it's going to be the elected officials, it's going to be the people on that authority that are going to have to make those very difficult decisions about making sure that people that fund this, okay, we don't go bankrupt, because the cost involved could be unbelievable, hundreds of millions of dollars. And when you don't have any more money, you can't treat the people you want to treat. But to your point, Jacqueline, it is extremely important that we always remember that it's for the patient. Patient is first. And with that are all the cost constraints that go with managing hundreds of millions of dollars in assets and resources and liabilities to run a hospital, because I've seen it, hospitals that have the best intentions, and they go belly up because they can't pay their St. Vincent's. And that was there from 1860. They went bankrupt. That's it. They closed the doors. They were $1 billion in debt. So if you don't manage your resources properly, you go belly up. That's what it is in the healthcare system in our country, unfortunately.
But the problem is, sir, is that when I was in London...
Actually, I want to go
We kind of have to move on.
Yeah. Well, just a comment, by the way, John mentioned Hackensack University Medical Center. I read a release today in my office, or some communique from them, that they're linking up with something else. And I said, half jokingly, but really seriously, I need a flow chart. It is so complex and so confusing. And you can use Hackensack University Medical Center with Hackensack University, Pascack Valley. I mean, it's almost impossible to even figure out who owns what in there. And I'm serious about that. I said to somebody on staff, I need a flow chart to let me know about what all these joint ventures mean.
Yeah, some of the HUMC facilities are for-profit, and some of them are not.
Right,
It's
exactly. I pointed out that Bergen Regional was the first hospital in the state of New Jersey, which is why this fight took place 19 years ago, to move to a for-profit model. And subsequently, many other hospitals have done that. But I'd like to maybe just ask a question here. I don't know if Freeholder Felice or Freeholder Di Nicola might know. Have they actually paid, has the management company paid the loans back that they're supposed to pay? Let me point out that one of the things, the day they took over the operation, March 1998. Yeah, March 15th, 1998. There was $27 million owed from third-party payers. They weren't in question, it was just in the pipeline, paperwork and so on. $27 million worth of care that Bergen County had paid for in their taxes to be reimbursed by these third-party payers. All of that was turned over to the then new management. And the proviso was there would be the awful part of the contract too. There was a promissory note. They got that money with no interest, by the way, until March of 2015. And then they were supposed to start paying a small interest on the loan. And the repayment was not due until March of 2020, 3 years after the contract expired.
And to add sort of a very interesting sort of question around this issue of receivables, if you actually read the story online that was on the record this week, there's a suggestion that there may be $30 million of receivables that will continue to go to the current.
And they already got those receivables.
And then the question is, what does the new management does it have to pick that up, and sort of how does that get carried, and with what borrowing mechanism do you use to make that work? These issues are exceedingly complex, folks, and I hope we haven't sort of in the course of this scared away. Are there any questions? Does anybody else have a, yes, sir?
Right here.
I just want to say something about, you're all talking about a hospital. Bergen Regional is quite the hybrid. If you look at 574 beds in long-term care, you're looking at a medical homeless shelter. That's what Bergen Regional provides. If you look at a Care One in Ridgewood or a Care One in Paramus, it's not the typical patients. So not only do you need nursing care, you need the social service component. I mean, there are gang members with, teardrops tattooed on their faces and long-term care. There's all sorts of things. So not only is it physically complex and financially complex, but the patients are not what you get at Hackensack University Medical
Of course not. That's why.
Or not what you get at the county. So I would hope that when this group looks at it, they look at the big picture. You see not only what the site patient needs, but also the long-term care needs.
And I think that's why it's very likely that no one organization can manage the totality of Bergen Regional because of the facets, the multiple patient care facets that exist. I mean, besides the size of it, you know, it's like bigger than Bellevue, which is hard to believe. But there's so many different facets. We may, and that's why the time that it's going to take to select that management organization or multiple ones is going to take longer because maybe organization A has certain skill sets and experiences that are best practices here, but maybe for psychiatric it's over here, for substance abuse it's another organization. And I think that it's how many people, there are very few people that can, unless you're in it, in the trenches, with some of the staff are, but to be able to bring it all together to have a single entity. So that's, I think, another layer of complexity. And if I could just add, just the complexity of the equipment, and the contracts, and all the things.
Who does it belong to? Yeah.
Right. Are going to have to be then merged to that new, and to your point, Irene, do they come null and void? Who picks up those plethora of contracts are probably in the tens of millions of dollars. So this is one of the most complex activities that I've ever been a part of. And I'm, in my own profession, are involved in a lot of hospital mergers on the vendor side. And on the vendor side, it's only a single product line. But here, they're talking about hundreds of different points that need to be addressed before it comes to
I want to, again, congratulate the advisory committee for its constant driving sort of message in this report. Think creatively. Think about what kind of things you have to put together in order to make the management structure work. And that comes through so powerfully in this report. That's what I think any governmental report that I've seen in the past. Sir, you had a question back there?
Yes.
Oh, sorry.
If I could also encourage the panel members to use a mic.
Oh.
Yeah, let me just say, I think, I mean, my part was to pass the law to give the structure, which I think in conjunction with the governor, although he chose to conditionally veto it, we decided to go along with it because the better part of the law was still there. So we gave the structure to the county that can be the overall governing board. You have the county executive who has made a commitment that this hospital will not be sold to a private or profit company or to anybody for that matter. And by the way, the 19-year lease was the 19-year lease because the 20-year lease would have constituted, under the state law, would have constituted a sale and would have required much more oversight. That's why it's this kind of oddball 19-year lease. So we have a commitment to keep it a public hospital. We have the structure in place that the county can hopefully use to good advantage. So the pieces are there, but the complexity needs to be filled in. And that's why I don't think that this 11th hour cudgel should be held over everybody's head. The point is to do it right and not get us involved with what the county and that county executive did 19 years ago.
We promise you get out of here by 9 o'clock. I'd like to ask you, since we started about 8 minutes late, give us 5 more minutes and your question, sir.
Promise to be fast. My name is Bob Davis. I'm an addictions counselor at Bergen Regional. I work in a short-term program with the old patients for 21 days. At the end of our time, if we feel the patient needs it, we send them to another facility for more treatment. Insurance is a big problem, there's no doubt about that. And the lack of insurance that's accepted at Bergen Regional is a problem also. But I have to say that I personally have never seen a patient turned away. Usually they're brought in under pending charity care, and efforts are made to try to get that patient some sort of insurance. But what I'd like to see Bergen Regional do is something that other programs do that we refer patients to. In the southern counties of New Jersey, they have something called South Jersey Initiative, where the counties have gotten together, put in a fund to help pay for the care of their substance abuse citizens. We could do something like that. Also, the IME program, which is run by the state. For some reason, in Bergen County, we don't use those, and I think if we did, that might help in the funding for the hospital, or maybe keep some of the costs down.
Do you think you have anything to say about that? I didn't know about that. That's very interesting, very helpful. One more question, and then we'll
I'm Srikanth Reddy. I'm board certified addiction psychiatrist from Oakland, New Jersey. I work at Bergen Regional Medical Center. Thank you for all your work to continue the service at Bergen Regional, which we all understand the need and necessity to continue the services. But my very important question that comes to my mind when I heard one of the panel members talk about St. Mary's in Passaic. One of the great things that the new executive, Mr. Tedesco, has done is, or we all have done, is to take an initiative not to sell the hospital and try to, get a better contractor who can, I guess, do better things. But what are we taking any measures to prevent what happened in St. Mary's? Because St. Mary's was, if I might be understanding this wrong, but I think St. Mary's was trying to do the same. But it came to a point where they were pretty close to being bankrupt, and they were not able to pay checks to their employees, and they had to ultimately sell it to a private organization in California. Are we at risk for that, or are we taking any measures to prevent that?
Can we get a yes or no answer on that, or not?
The answer is different. You're a public entity, and there are different things involved. That was a non-profit entity, and it made decisions, and ultimately its board was its non-profit board, which was one form of the Sisters of Charity, had an obligation to keep this hospital either to close it or not, when they were bankrupt. And my comment had to do with that there were alternative choices that they were faced with, even though they claimed this was their only option to do, but close it. When I had gone through the papers, it was clear that there was another bidder who was looking at downsizing the hospital and also doing assisted living for veterans. So you're not at risk of that to the extent that you're a public entity. And the public entity has other choices and it has other means to do things, and it's publicly accountable in a way that a nonprofit board is not accountable. A nonprofit is a private entity, the same as a for-profit.
I'd like to actually bring the discussion to a conclusion. I want to thank you all for being here tonight. I want to especially thank this really quite marvelous panel, which I think it actually provided everything I was hoping it might actually come out in terms both of perspectives and of sort of, there's also, you probably sense not only a difference in perspective looking at these issues, questions differently, but also a surprising consensus about what Bergen Regional both is and must continue to be and become, which I actually find reflected much more generally in the decision-making forces within both the executive in the county and also your legislative body, your freeholders, which is, I think, very good news for us. And those of you who are interested in sort of checking on whether or not that's true for the freeholders may want to come back to the same hall on the 26th, a week from Wednesday, 8 days away, and hear all 7 of the 8 freeholder candidates discuss what they want this county to become from the legislative side. And then the very next day, we will be asking the people who are running for the clerk, the surrogate, and the sheriff of the county. We have 2 candidates each from each of the major parties debating those issues. Thank you very much for coming, and I'd like a round of applause.